We are live, Dr. Patty.
Thank you. Good morning and welcome board and online viewers to the May 7th Board of Health meeting for Louisville Metro. The board meeting is officially called to order at 8 a.m. This virtual meeting is being streamed via YouTube. This offers the ability for people to comment, and it also serves as a repository for all meetings that anyone can access later on. The meeting will also be rebroadcast on Facebook. The March board health minutes were distributed to the board for their review prior to this meeting. Are there any discussions or amendments to the minutes?
I move the adopt.
Thank you very much, Ms. Margolis. May I have a second?
I'll give a second.
Thank you. All in favor, please raise your hand, and Ms. Delano, you can voice out your vote. Can we count, Arlena? Thank you. Any opposed? Please raise your hand. Any abstentions? The motion is approved as distributed. Thank you so much. I would like to welcome Dr. Kathy B. Baumgartner. She is the School of Public Health and new interim dean and professor. She is the Associate Dean for Academic and Faculty Affairs Administration and Epidemiology and Population Health. Dr. Baumgartner is a cancer epidemiologist. So Dr. Baumgartner, you're gonna like our presentation today. She has extensive experience designing and conducting large population-based studies. She joined our meeting last month. I'm sorry I didn't introduce you properly. Welcome, Dr. Baumgartner. Dr. Katie Cardarelli was named University of Louisville's interim executive vice president and university provost at the end of March. That's the reason for her absence and her replacement by Dr. Baumgartner. I would like to do a public acknowledge and thanksgiving for her work, compromise, and participation with Louisville Metropolitan Health and Wellness Board of Health, and for her commitment to the public health of our community. A couple of reminders. Please remember that in May, all board and commission members will need to complete the ethics training, so be on the lookout for the email. This virtual training will give you an overview of the Ethics Code, Open Records and Open Meetings Acts, and board accountability and oversight. The entire board must watch the training, and this training, as well as financial disclosure documents, will be sent to your email account. If members have already completed the disclosure for this year, they can disregard it. The training and disclosure documents will be sent both to your personal email and to your board's email. However, the proof of receipt is only be completed once. Also, keep in mind regarding your Metro Board email account that you need to open it at least once a month to avoid being locked up. If you have been locked up, please contact Arlana and let her know so she can put you in contact with the IT department so you can reactivate your account. According to the Society of Public Health Education, May is the month for women's health and also the mental health month and the water-related accidents prevention month. So with this, many states have launched different programs. The Commonwealth through the Kentucky Department of Behavioral Health and collaborators in 7 counties in our Jefferson County. As the local administration, they are launching a campaign to promote 988. And this number, the 988, has made access during crisis a lot easier. So let's promote the use of this number. Metro United Way shared with us that U of L currently has an exhibit focused on impact of lead. So this exhibit is open to the public, but the best part of this is this can be accessed via electronically, so it can be virtual. We'll share with you the link so you can also participate with this exhibit. And again, the reminder that the cases for measles have been escalating. Now we're, as of May 2nd, 935 cases of measles in the country. and 92% of them are younger than 19 years old kids. And this is worrisome, but more worrisome is that also by April 2025, 9,000 cases of whooping cough were reported in the US, nearly double the number at the same time than 2024. And this is according to the CDC. So the best way to prevent these infections is vaccination. Let's promote vaccination. Parents, if you're listening, if you get to see this video, please, vaccination is the best way to prevent infections. So for our perspective session this month, we have the Southern Environmental Health Study, a new study to understand cancer risk in the US South. The presenter is Dr. Marta Shrubsole, Professor of Medicine, co-lead Cancer Epidemiology Research Program with the Vanderbilt Ingram Cancer Center. Dr. Shrubsole is a professor, and she co-leads the Cancer Epidemiology Research Program at the Vanderbilt Ingram Cancer Center with the Vanderbilt University Medical Center. She leads a research portfolio of molecular and modifiable risk factors epidemiology. The major focus of her work is to identify factors related to cancer risk with the eventual goal of helping to prevent or delay cancer. She is also the primary investigator of the Southern Community Cohort Study and the Southern Environmental Health Study. These are two large NCI-funded cohort studies seeking to understand cancer risk in the US South. Dr. Shrubsole has had leading roles in multiple trials and other large-scale epidemiological studies based in the US and globally. Today I present you Dr. Marta Shrubsole. Welcome, Dr. Shrubsole. You can start.
Thank you. Can you please confirm that you can hear me?
Yes.
Great. Thank you.
We can see your presentation as well.
Excellent. Well, thank you for the opportunity to share about a new and ongoing study that we are doing in partnership with Family Health Centers, as well as some other partners, as well as I'm going to take a moment to highlight some of the past work we've done that's also still having an impact on our understanding of cancer. I like to always start with the good news about cancer because especially when we hear that word, there's a lot of feelings and emotions it brings up. And when we work on it, we're always trying to do better. But we have seen a slow but steady decline in the number of new cases as well as in the mortality rate of cancer overall. But there's still work to do. So we have also seen this increase in 5-year survival. So a diagnosis of cancer in 2023 is quite different than a diagnosis of cancer was in 1975. There will, however, be over 2 million individuals diagnosed with a new cancer, and hear those words, in 2025, including over 4,000 in Jefferson County. And so there is yet work to do to help us try to both prevent that as well as to increase the chances of survival. One of the reasons that we are doing work in the South, beyond the fact that we live there, is that when we look at these cancer maps with the incidence or new cancer cases on the left and the death rates on the right, all of those spots with the dark red are those with the highest rates compared to other parts of the US. And although certainly we see red across many different areas, there's a lot of red in the South and a lot of orange in the South. And so we want to be doing work to understand cancer in the places where it has the largest burden. That includes within the state of Kentucky. These are some maps provided both by your cancer registry as well as by Louisville Metro, looking at cancer rates. And we can see that there's certainly variation even within the state of Kentucky as to where higher rates are versus lower rates, and within Metro Louisville as well. So I'm a cancer epidemiologist, and what that means is that I use epidemiology tools, one of which I'll be talking about today, to try to understand what we call the cancer continuum, and namely that going across from understanding etiology, prevention, detection, diagnosis, treatment, and survivorship. And the work that I'm going to be describing today is really focused on this first two boxes here, trying to understand those things that may be increasing risk or causing cancer, as well as things that might be informative for how we can prevent it. So one of the key tools that we have in epidemiology is a cohort study. And in this type of research project, we recruit people who have no cancer and we follow them through time. We will first find out, are they exposed to our thing of interest or not? So that could be something like tobacco use, or it could be something like, something that's present in the water. Are they exposed or not exposed? Follow them through time and see who goes on to develop the disease and who doesn't develop the disease. And this allows us to then do comparisons between our exposed and not exposed to see if there's no difference in those rates between exposed and not exposed and who gets to disease and not. There's no association. But if there are differences, then we say there's increased risk or decreased risk. And one of the reasons this is really important and a key tool and powerful is because we assess those exposures before people go on to develop the disease. So we know, for example, it doesn't affect their memory, or the time, we capture the period as the risk of cancer or the cancer itself was starting. So I want to start by giving an example of how these can be really useful tools. The Southern Community Cohort Study is a study that we're still doing. It's still funded by National Cancer Institute and was a partnership with 71 community health centers across the southeastern US, including family health centers, where 84,000 participants joined. To date, we have over 400 scientific publications and are publishing about 50 papers per year at this point. One of the ways that we've used this study is to try to understand who qualifies for lung cancer screening. Lung cancer screening became available a few years ago with low-dose CT scans, and we wanted to understand among our SDCS participants, those people that we knew developed cancer. So we know that they had lung cancer, and they would benefit from having that cancer detected early. How many of them would have qualified based on the guidelines at that time, which were based on age and smoking pack years? And so a colleague of mine, Melinda Aldrich, looked at this specifically, and we found that in SCCS, 58%, so more than half of the people who actually developed lung cancer were ineligible for screening, had at the time of their lung cancer based upon the criteria at that time. So in other words, missing a very large portion of the people that are most at risk for lung cancer. And we not only found that it did poorly overall, but the reasons for ineligibility varied, specifically among Black people and white people, so that it was bad for both groups, but it was particularly bad for individuals who are Black, where almost 70% were ineligible versus over 40%. And the reasons varied. Some of it was because of the pack year. There was a large difference in those who qualified based upon pack years, with Black persons were almost nearly half did not meet the pack year requirement. So based upon this, as well as based upon other work by other researchers, the USPSTF revised those screening recommendations in 2021 to lower the age of eligibility to 50 and to reduce the pack years eligibility from 30 pack years to 20 pack years. We are continuing to do some work in this area to see how those new recommendations are impacting, but that we were only really able to do this because people gave up their time to answer questions, to tell us about their smoking history, as well as gave us permission to find out whether they went on to develop cancer. So to switch now to our new project, when we think about the impact of exposures in our environment, we know that about 9 million deaths per year are attributed to air, water, and soil pollution, and this is specifically pollution. Obviously, when we think about the environment, there's more than just pollution going on, but that's quite a stark number to look at. Within the US South, we also have a lot of common exposures. Certainly we have air pollution, and that could be affected by heat exposure, which again, within the US, there's more heat exposure within the South than there is in other parts of the country. And then we also have common exposures that may be common elsewhere as well, but also are here, such as the forever chemicals or PFAS substances, water pollution, and other things. So when we think about sort of things from an environment, there's some very unique exposures or combinations that are occurring within the South. In terms of understanding how environment may impact on cancer, we know that a small proportion of cancers are driven solely by the genes that we're born with. About 80% of the cancer that occurs is caused by environmental exposures, as well as by lifestyles and how these things interact with our host susceptibility. In addition, the International Agency for Research on Cancer has estimated that 7 to 19% of human cancers may be due to environmental carcinogens. In fact, the National Toxicology Program in the US has identified over 250 substances identified as known or reasonably anticipated to cause cancer. And that sounds like a lot. However, we know that the EPA has over 80,000 chemicals that have been registered. Very, very few of these studies have ever been looked at in humans. And if they have been looked at, usually they've been looked at one at a time. Well, we live our lives being exposed to lots of different things. You know, there's a lot of benefits to living in our modern age, but it does mean that there are chemicals and exposures that didn't happen 100 years ago, maybe weren't even present 50 years ago. And so to understand the long-term consequences on health and be able to know these things are not things we need to worry about, or these things that we maybe need to reconsider how those exposures happen. It's really important to do studies to understand that. The cohort study that I talked about, the Southern Community Cohort Study, as well as a lot of other large cohort studies that have existed, don't have a person level external assessment of exposures. We haven't had a cost-efficient and scientifically valid way to measure some of those things, which we're trying to address in this new study, and I'll tell you about. We also have very few biomarkers to assess environmental exposure. So we can't just take a blood sample, run it, and say, oh, these are the things you've been exposed to in your life, and therefore you have this risk of cancer. So a lot of limitations to overcome. So to do that, we have tried to address many of these gaps by the Southern Environmental Health Study, which is another National Cancer Institute funded study. Again, this is a partnership with many different groups, including, I'm very pleased to be partnering with family health centers again to try to better understand and fill these gaps. One of the ways that we're doing that is taking what's called an exposome or exposome approach. Some of you may be familiar with the genome and other things. This is looking at it on an exposure level, where we really want to be able to collect information that captures all the different elements of our lives. So lifestyle factors, chemical exposures, social factors, the places that we live, and how we use those spaces. Another way that we were addressing the gaps in this study is to use silicone wristbands. These are to get that person level unique exposures at the person level that we have been missing from other studies. These are relatively new in terms of the development of this method. These are just regular silicone wristbands. You've probably had some from charities or other events over the years. We super clean them, and then through our chemical analysis, we can measure up to 1,400 chemical signals. So certainly this is not going to tell us everything. I told you there's 80,000 chemicals that have been registered, but this will tell us a lot more than the 0 that we had before at the person level. So these wristbands have been used in the past few years. They're used particularly in some of the firefighter studies to try to understand exposure, say, while on duty versus off, while on duty fighting fires versus on duties in the fire hall, postpartum mothers, looking at farmers and pesticide exposures, as well as some other work that has been done on a very small scale in the general public. But what we don't yet know is how these things relate to cancer, and that's what we're hoping to establish within this study. So our objective is to be able to look at the combination, take that exposome approach and look at the combination of all of these different elements at the risk of cancer and other chronic diseases. And to do this by systematically evaluating thousands of exposures using data from surveys, environmental monitoring, as well as to be able to do assays of biological and environmental samples with a goal of about 35,000 study participants when we close enrollment. So what does it involve for participants? They are giving up their time. What is it we're asking them to do and their information? The first is a survey. It takes about 30 to 60 minutes to complete. It's currently available online as well as by phone, and will be available on paper later this year. Also to wear that silicone for 7 days, we mail it to participants. They mail it back. We put it in the freezers. And then to give us permission to link to things like the cancer registry to be able to understand who will develop cancer, and some future surveys that are much, much shorter than the first one, about every 2 to maybe 4 years. Within Louisville, they can come to FHC to donate blood or urine, and we also have an at-home option to collect saliva sample. And for doing so, participants receive $20 for enrolling, completing the survey, and returning the wristband, $20 for the blood or urine, and $5 for providing the saliva. So who can do the study? It's any adult between the ages of 40 and 70 who lives in one of the southern US states. So we have 16 states as well as DC represented in this. So it's really, this is a great way for people who'd like to know, what can I do to help cancer? What can I do about cancer? This is something that we can all do to help with that. We ask a lot of questions about the health history as well as lifestyle in the survey. We are each the expert of our own lives. And so this is how we get at some of that information, where people are able to provide information such as their tobacco use, physical activity, their use of healthcare, how they, their water sources, medications, things like that. In addition, we ask people to provide information on places they've lived in their lives so that we can link that to things such as, did you grow up in a rural area or near agriculture? How far do you have to travel for healthcare? Do you live near an industry that may have some pollution as a source? Things like that. And it's really helpful to provide that additional level of information. All of the samples that are collected go straight into the freezer when we receive them. And then in the future, when we know who has developed cancer, we'll pull some among those who did and did not and compare them and test them for levels to look for differences between the two groups. I mentioned the linkage to information. It's really important to have that permission so that we can go on and know who has who's died, why they've died, also to know who has cancer. And then it also to give us the permission if there's any tissue that's left over if someone is diagnosed with cancer, so that we can collect that and see if there's differences at the tissue level based upon some of these exposures. We have many community partners and really value the input that they give, as well as the direction that they help to provide, including at community health centers, including FHC, as well as our community advisory board. We have a research advocate who's a cancer survivor that is part of our research team, and then always helpful to have participant feedback as well. We produce an annual newsletter for study participants and as well as our partners to send out to give updates. Because we're in a building stage of the study, it's mostly related to how we're doing on that regard. But we look forward to the day that we're going to be able to put some results in those as well, that we're learning from testing this, the samples themselves and the combining the information from the survey. And then we'll be also providing ways for people to obtain that information as well. We currently have over 14,000 participants spread across the South, and each of these red dots represents a participant. This map's a couple of months old now, but you can see that we have some good representation across the South, and hope to see more red on there as well. A specific thing that I would ask of you is, would you be willing to help us spread the word about this opportunity for people to participate? I have put here Kristen's phone number as well as her email address if anyone is interested in having, say, flyers to post or events that we could attend, the group could attend, that would be great. Opportunities to put it in newsletters and in community events. If you have waiting room TVs, things like that. Basically just trying to get this in front of as many eyes as possible so that people have the opportunity to participate, should they choose to do so. And then finally, I also want to make sure and extend a personal invitation that if you are between the ages of 40 to 70 and you live in Kentucky here, you are welcome to also consider joining the study. And you can find information at our website, which will also can make sure that we circulate at the end. And with that, I'll be happy to take any questions.
Thank you very much, Dr. Shrubsole. Does anybody have any questions for her?
This is Dr. Shaw. I had a quick question. How in this study, how do you control for confounding factors, right? Because I mean, once you get sort of the cancer diagnosis, it's tough, right? I mean, there's so many things that go through your mind as a patient, and you're sort of how do you figure that out, I guess, or separate it from what the reality is?
Yeah, so there's a couple of different ways that we do that. I mean, the most important thing is that we have to measure those confounders, right? We have to collect information about them. So when we design the study, we collect a lot of information about the individual because there may be confounding there. But we also collect a lot of information, say, about the communities that they're in, so that we can actually evaluate that. So when it comes to the point of doing the actual, say, statistical analysis, there's a couple of different approaches. One of those are things that we know are confounders ahead of time. So we make sure we've collected those and do that. And then there's also statistical testing for confounders. So that is the way that we do that, as well as trying to do some things to compare how stable those relationships are when we say take some samples out and put some samples in. So there's a few different approaches that we take to try to address that.
Thank you. Anybody? Yes, go ahead.
I just the wonderful presentation. I was very impressed by the cancer study continuum that you talked about, and it ends with your newsletter to inform those people who have been screened about what's going on, and of course a feedback, but a very nice newsletter that you said you all helped to create afterwards. Now, as far as screening is concerned, what do you include those cases who have inadvertently been diagnosed with cancer, who inadvertently get, an X-ray or something like that, and then we follow through and we find out, we do more tests and realize that this is actually a malignant nodule with or without a history of exposure to smoking and so on. So
yeah, that's a great question. So the information that we get about whether or not someone has been diagnosed with cancer comes primarily from the state cancer registry. So those are going to be those reportable cases to the state cancer registries. We do have some self-report that happens in our previous studies, and will certainly happen in this one as well. And then we do try to follow that up just to see, but since we're not actually doing the diagnosis ourselves, that's, their standard of care. Certainly, when you think about 34,000, 35,000, 84,000 people, we're not able to be a part of that process. But we rely solely on the cancer registries and the high quality data that they provide.
thank you.
Thank you. Anybody else?
Where do we find or have the ability to mine the data that you all have gathered, as far as finding the causes or just exploring that?
Yeah, so right now we're still in the building phase. Once we move past that, there will be a process to open it up for people to apply for permission to use the data in a way that we can still maintain the security and privacy. So we're not yet at that phase of the study, but that will be something that comes. In the Southern Community Cohort Study, we have a website, southern.community.study.org, I think it is. Southern Community, if you put Southern Community Cohort Study, it'll come up. And there's a full month, we review applications on a monthly basis for people to apply and use data from that.
Okay, thank you.
Thank you. Anybody else?
See a hand up, yeah.
Please go ahead.
I think this is a really interesting and really amazing, and especially the use of like the bands, the synthetic bands, as like a millennial or like a mother. I know that that's something that I think would appeal to. I know the study is for older people, but I think that's something that's going to appeal to a lot more people in probably about a decade. But I just wanted to know how you kind of like recollect that data, and like how long do people wear them? Do they send them in to you? How does that process kind of work?
So they wear it for 7 days, 24/7. So you can wear it swimming, bathing, putting on lotion, all of the above. So you wear it for 7 days. We send it just through the regular mail to participants, provide them with a postage paid return envelope for them to send it back to our lab. We will be doing some very limited basis, getting a second sample from a small number of people so that we can kind of compare over time. But obviously doing some additional collection, a few years down the road would be great, but that is not part of the current grant funding approval.
Thank you. Anybody else? I just want to acknowledge the design of your project and how you compensate the participants. It's so important to recognize their time and their input. I know they will get a benefit, but just recognizing that, it's commendable. So we're looking forward to hear more from this cohort study. And please share the email address or the site that we need to visit, and
Yes,
we'll
we will
make
do
sure
that.
to promote.
Great.
Thank you so much,
for the
Dr. Schultz.
opportunity.
Appreciate it. Thank you so much. Okay, now we will continue our agenda and allow time and space for updates and reports. For the mayor's office update, do we have Deputy Mayor George? She is not in the meeting. Do we have a representative?
I believe there was a meeting at the mayor's office this morning. So I don't think that, I believe
Okay.
that's the reason why she's not attending.
Thank you very much, Arlene. Appreciate it. For the director's update, now I yield the floor to Stacy Ingram. She's the director for Louisville Metropolitan and Wellness Health Services, who will give the director's report for replacing our chief health strategist, Connie Mendel. The floor is
Thank you.
yours, Ms. Ingram.
Thank you. Good morning. The full report is attached with the email that went out before the meeting. I just want to call out some highlights. We are currently having our spotted tick and share program. So folks can bring in ticks that they have found in the community, helps us identify new species and know what is in our local areas. Our harm reduction outreach services now has the capacity to respond to community requests to clean up syringe litter. So if you have folks that have issues in their neighborhood or they're seeing syringe litter, the details on how to do that are in the attachment. We also want to welcome Dr. Carmen Mitchell as the new director for our Center for Health Equity, and Ben Goldman, who has been promoted to the Director of Behavioral Health with our department. And that is my update. Thank you.
Thank you so much, Ms. Ingram. I think I saw Dr. Singal is not present, is it?
I
Ms.
don't
Ingram?
believe he is.
Okay, thank you so much. We are going out with family health centers. Now I yield the floor to Dr. Bart Irwin.
All right, thank you. I'd like to give you a quick snapshot of indigent care in Louisville, who's using indigent care, at least at family health centers. Family health center serves about 1 in 20 persons annually who reside in Jefferson County. We served 39,773 individuals last year, and that's an increase of about 1,600 patients for the year. 25% of those patients were ages 17 and under. 32% were Black, 54% were white. Ethnicity, 40% were Hispanic. And in regard to language, 45% of the patients we served, about 18,000, did not speak English well enough to be served in English. That's an increase of about 2,800 patients over 2023. Most limited English-speaking patients were Spanish, about 89%. Income-wise, about 88% of persons served by family health centers were 100% of poverty or below, and 98% were 200% of poverty or below. 53% had Medicaid as a third-party payer, 8.7% had Medicare, 12.17% had private insurance. We've been seeing that increase. Private insurance can include automobile accidents, slips and falls, that kind of thing. We speculate that persons moving off of Medicaid some of them are getting the qualified health plans through the state and through connectors. 25% of our patients that we served last year were uninsured. In regard to Medicaid, we have witnessed a pretty steep decline in the number of visits that we provide, medical visits provided. It used to be at the height of the pandemic that about 63.7% of our patients had Medicaid. That's dropped now 13.7% down to about 50%. So we're watching that trend carefully. We're happy to see that in Jefferson County, and I would imagine this applies to the state as well, that the drop in persons being covered by Medicaid has stopped, has become more stable. So we're happy to see that. The number of uninsured visits overall remains at about 25%. The top 3 diagnoses that were provided to patients were Hypertension, diabetes, and depression were the top three. And in 2025, Family Health Centers administered 29,509 vaccinations. Most of those were children, about 83%, but not exclusively. So that's a brief update of what's happening in primary care, at least at Family Health Centers. Any questions?
Thank you so much, Dr. Irwin. Any questions for him? What a great service Family Health Center is doing for our community.
I have a question, and I think Heather has a question as well. So,
Hey, Scott.
Go ahead, Dr. Hedges.
yeah, Bart, I'm just curious. I don't know if you have data that tracks this, but do you have a sense of whether or not, as people move off of Medicaid rolls and have some other access to care, how many of those are moving into the no insurance category? How many of those are moving into insurances that are provided through some other mechanism? And are they electing to stay with family health care as their primary care provider, or are you losing it? Do you see attrition because of that?
Scott, it's hard for us to track individual situations. We can only look at more high-level trend. I can tell you that, as I'd mentioned, our Medicaid has decreased, our private insurance has increased. So there's got to be some relationship there. My guess is probably mostly through the state exchange. People are gaining insurance. We have 8 connectors through our healthcare system who assist patients. And maybe I could get some data from them.
I have a question.
Go ahead, Ms. Margolis.
Thank you. This is a question because I'm following fairly closely reimbursement methodology through CMS and what's going on right now in Congress as it relates to FMAP, the limits in terms of income eligibility. And I just want to ensure that someone on both the city's team and also in your area, Bart, are watching this closely. Now, while the moderates in Congress have an inclination to not reduce the eligibility levels, and most will remember that it was that eligibility went up to 150 and down to, I think it's about 138 now. I could be wrong. Dr. Irwin, you can correct me, but I just want to make sure we're monitoring this because it will have impact on the city and on budget processes that are going on right now. And that people contact, I mean, clearly, Morgan, Carthy is on our side. But the governor will have a role, and given his bipartisan view by both sides of the aisle, I think it would be a benefit.
Yeah, Ms. Margolis, we are, Family Health Centers is keeping a very close watch. We're in contact with state advocates and federal advocates and are keeping up to date on what's happening and pushing back wherever we can. Don't know how much power we have to do that, but we're using those methods that we have available to us.
Well, a lot more than paid lobbyists.
Yeah, yeah.
But, well, I'm going to stop before I say something that I won't regret, but I don't want it for posterity in the record.
Thank you. Anybody else? Any other question for Dr. Irwin? If not, we go to healthcare coverage and outreach with Ms. Doris Basson-Jorferman.
Hello, good morning. I just have, can you all hear me? I know last time you all weren't able to. Okay.
Yes.
I have a few updates, not much, but with meeting with KPE last week, they did give us some information in regards to the possible, the changes that may occur in a possible timeline for some of those things. So there is something in process to prevent, for qualified health plan members, to prevent gender affirming care. So whenever it comes to the billing side, those those procedures for those patients will not be covered. So they'll be responsible for those. They are also, let's see, changing the special enrollment period, which is not the smartest thing to do. It will no longer be November 1st to January. They are actually trying to just 1 month, November 1st to December 31st, which is not going to allow people to enroll, because with whenever it's come time to enroll, we mostly see the bulk of people towards the end, because they're forgetting, or they have to get things together and figure things out. So this short timeline will cause a lot of issues, and I believe that's probably what they're trying to do, is have less people enroll and have health insurance, which doesn't make any sense. But they're thinking this may take effect in 2027. And they're thinking this is something that may be for sure, so it's unfortunate. Also, they're still trying to look into the pregnancy special enrollment, so that is still being provided to pregnant women, that they can still enroll for when they're pregnant as a special enrollment for now. So they are trying to make sure that stays intact. And for other special enrollments, they are trying to do a fraud detection. So they're basically having to do more verifications. So instead of a client telling us that something happened, or client statement, they have to actually provide verification documents and things like that to verify their special enrollment and if they qualify. So we can't just take the client statement for that. So that may become a little difficult for some, and it is going to be more paperwork. So I don't know how they're going to manage to do that, but that is something that is set to take place. And also, 2 Fridays ago, the parolees were set to end and be denied for coverage. So that is, the federal judge did block that. So at the moment, those that are paroled that through the Biden program are still able to get coverage as of now. So hopefully that stays for now. So also, in regards to that, nothing else has really changed. They do see that the APTC may end in December 2025. So that tax credit that the state was providing assistance to those clients, that will end, unfortunately, as well. But they're not letting clients know that yet, because they're still trying to figure things out, so they don't panic. But that is all, I believe. The immigration parole, however, for the Haitian and Cuban entrants, they a lot of the parolees that have TPS, which is that temporary protective status, they will lose that status. But for the Haitian Cuban entrants, and it could also possibly for the Afghanistan and Ukrainians, they may still have that eligibility to get coverage for Medicaid, but they're still checking into that also. But that is my report, I believe. Any questions?
Thank you, Ms. Furman. Very worrisome news.
Yeah.
Does anybody have any questions for Ms. Furman? Thank you so much. So now we go to JCPS Health, and I yield the floor to Dr. Eva Stone.
Good morning. I really don't have any updates. We have just the rest of this week and next week left of school. The 23rd is the last day of school for students. We're just trying to hang on and get through. State testing started yesterday, so most of the schools will be engaged in standardized testing over the next couple of weeks. But we're still carrying on with vaccine clinics and those things. We did our last vision clinic for the year yesterday at Newcomer Academy. Dr. Single and his team helped with that. It was a very busy day, but an excellent day. And we're really grateful for the Darsh Foundation and Vision Works for helping partner with us to do that. In June, we will be doing 2 weeks worth of clinics around the city at high schools, where we'll be offering physicals, athletic physicals, vaccines. Shawnee Christian Care is going to partner with us to vaccinate kids who have private insurance at those clinics. And then I talked to Dr. Single yesterday. They actually may be there to do some vision things as well. So excited about that. And then we'll be doing several back to school events. It's hard to believe, but we're already gearing up for next school year. But because the first day of school is the first week of August, it's August 7th or 8th. So there won't be too much downtime. JCPS will have summer programming going on too. The last couple of weeks of June and the first couple of weeks of July, there'll be lots of summer programs across the city going on as well. So, of course, you've seen the superintendent search is happening, and so there's all that in the works also.
Yeah, there are 2 candidates, I believe, and if I believe media that I read or hear.
I have not.
This morning.
I know there was a meeting yesterday. Yeah.
Thank you so much for all the great work.
The person loves public health.
Yes.
Say that again.
We hope that the selection involves someone who is a big supporter of public health.
Absolutely.
Mm-hmm.
And we're very grateful for the partnerships that we have, but I just want to be clear when I tell everybody that for the K-12 population, in early childhood as well, vaccination rates are nowhere near what they need to be. Nowhere near. And if we have a case of measles in some parts of the city, it's going to be difficult and challenging. If it's in a time when school's in session, we're talking about long quarantine periods for those who don't want to be vaccinated. And so we've been doing a lot of work reminding nurses at the school level that they need to aim for that 95% herd immunity. And so, but we're not in the city as a whole where we need to be.
Thank you so much for the reminding about vaccination. So, we will continue speaking for the vaccination. And thank you for all the great job that JCPS is doing for our community. Appreciate it.
Thank you all.
Thank you. Do we have a representative for Greater Louisville Medical Society? Dr. Anita, I'm sorry, Dr. Bhatia. I'm sorry.
Hello.
Go ahead, please.
Good morning again to everybody. My update is that we have the new slate moving forward of the officers of the GLMS. And on the 10th of May at 1 p.m., we have the President's celebration and inauguration at the Louisville Slugger Museum. With that, I would be moving on to President-elect position, and Dr. Jeffrey Goldberg is going to be the new vice president, and so he will come and join you all. And I have had a wonderful experience. I'm sure he will enjoy it too. It has been very rich, the whole entire experience of learning what happens at the Louisville Metro Public Health and Wellness Committee. So I am very grateful for that opportunity. Thank you. And I wanted to mention that our medical students are becoming more and more active. They actually hosted a dinner for the officers of GLMS because they want to be involved in the resolution formation and involved in the changes that they want in our state of Kentucky. So we will be meeting with them on June 16th again. But that's June 16th is the day that GLMS has their first meeting for resolutions formation and submissions. And then, of course, we clean them up and then allow them to be submitted to the KMA, after which they do go on to Frankfurt. On a personal this thing aside, I did go and attend with the Kentucky Hospital Association. This does not have to do anything with the GLMS, so maybe I will only mention that we went to Washington, D.C., and met with our senators and our House representatives from Kentucky and talked about the new budget discussions that are happening and the deliberations that are happening and how they would be affecting our Medicare and Medicaid in our state. So thank you very much again for this opportunity to join you all.
Thank you so much, Dr. Bhatia, and thank you for being with us for this year. Best of luck on the next. For the Kentucky Nurses Association, Ms. Delenor Manson. Ms. Delenor, can you speak?
I can.
Yeah, thank you.
This month, May, is Nurses Month. So if you see a nurse or you know a nurse, make sure you say thank you for the work that they have done. We're having our advocacy and leadership conference on May the 23rd at Western Kentucky University. We have 2 national speakers and a panel discussion with legislators. So it's an opportunity to get to know those legislators and help them to understand the importance of what nurses can bring to them in terms of developing legislation. We had our measles class. We had 101 individuals to attend. The class was provided by Dr. Ruth Carrico, and she is going to provide a second class that is designated just for community members and parents, and we'll do that in June. We continue to focus on workplace safety. As you all know, we passed a bill, HB 176, 2 years ago, and that bill was amended to a point of not really focusing on workplace safety. It was focused on how do we protect organizations from having to implement safety assessments and protections. So we're at it again. So for this next session, we will be focused on how do we remove those amendments or pass another bill that will provide a safe environments for all healthcare professionals. And so one of the things that we are interested in doing is working with a coalition of healthcare professionals to say this isn't just a nurses issue, it's a healthcare professionals issue. 1 in 5 healthcare professionals are injured on the job, and that's more than policemen who carry guns. So if you're interested in working with us to improve our healthcare environments to make them more safe for the individuals who are there to provide the care, please contact me. We can use all the help that.
Thank you so much, Ms. Manson. Do we have any questions for her? And if you please could share the link for Dr. Carrico's talk and presentation for the community so we can distribute it or make it accessible for anybody that is interested. Thank you so much.
Absolutely.
Appreciate it. For the Greater Louisville Inc., do we have Ms. Shelby Somerville? I don't think we do. And for the Immunizations Committee, Dr. Carrico, would you like to participate?
Sure. Thanks. We are still trying to look at our overall ability to influence immunization within the community. We have a number, as we've already heard, then a number of initiatives that are occurring with all of the multiple partners. I think it's clear that we are still lacking some focus on adult immunization. And I think Dr. Severe, you had mentioned the current measles outbreak that we are having. And although that the greatest number are in children, we still have unimmunized adults that are experiencing a disease and hospitalization. So we know that that is a gap. How we provide that is still one of our challenges, and I look forward to trying to figure out how we will add that approach as well to the many, although still not, as Eva mentioned, not enough influence and impact on pediatric immunization, but looking at this as a total population need. So we'll keep at it.
I agree. A total population need. Thank you so much,
Yes.
Dr. Carrico. Looking forward to keep on working with you. And with this, we're almost at the end. Is there any old business? Any new business from the board? If not, thank you very much for taking time to participate in this month's meeting. The next meeting will be held on Wednesday, June 4th at 8 a.m. And again, this will be a virtual meeting. If there is no further business, the meeting is officially adjourned. Thank you so much, everybody, for participating today. Thank you. Appreciate
Thank
it.
you. Thank you.
See you next month.